Welcome to our podcast, where we delve into the evolving landscape of healthcare, starting with one of its most rapidly expanding areas, and that's office-based anesthesia, also known as OBA. This field has witnessed exponential growth over the last decades, driven largely by the massive increase in demand for cosmetic surgery, with current estimates pointing to around 10 million procedures per year performed outside of hospitals and ambulatory surgery centers, or ASCs. Patients are increasingly seeking OBA due to its distinct advantages, and these include things like ease of scheduling, greater privacy, lower costs, increased efficiency, and unparalleled convenience. The shift means that procedures and patients traditionally confined to hospital settings are now frequently being considered for outpatient office environments. Despite its current popularity, office-based anesthesia initially faced significant professional skepticism regarding its safety, with even some calling it the wild, wild west of healthcare. Now, those concerns really arose from a lack of mandated reporting as well as regulation across many states, and the perception that offices might not possess the resources or even adhere to the same standards as hospitals or accredited ASCs. However, there are numerous current studies that now attest to the safety of surgery and anesthesia performed in some of these accredited office-based facilities by specialists, and this is really important, practicing within their credential as well as expertise. Organizations like the American Association of Nurse Anesthetists have actively addressed these concerns, publishing comprehensive guidelines and emphasizing that the standards of care in hospitals and ASCs also apply to office-based anesthesia. Now, this dedication to standardization and quality improvement has greatly bolstered ABA's standing in the medical community. Now, a core of modern office-based anesthesia's success today lies in the sophisticated anesthetic techniques, which often deliver an experience superior to conventional general anesthesia that are performed in most hospital settings. For example, most OBAs practice, like the Dudley Street Operatory, utilize deep sedation with propofol ketamine infusions combined with local anesthetic injections. That allows the patient to be calm and unaware without the need for invasive airway devices, paralyzing agents, as well as anesthetic gases. Now, this approach avoids common postoperative issues like sore throats, postoperative nausea and vomiting, and more importantly, provides effective postoperative analgesia, which contributes to that pleasant recovery profile for the patient. Now, patients are informed that they won't receive conventional general anesthesia, but will experience continuous intravenous sedation, and that ensures their comfort and minimal recollection during the procedure. Now, looking ahead, the future of office-based anesthesia appears to be pretty robust, with a sharpening focus on continuous improvement as well as patient safety. Now, this involves optimizing care through what is known as the 4 C's: communication, competency, connectivity, and collaboration. These are a vital emphasis on providing effective office-based anesthesia safety education for anesthesia professionals, as well as implementing customizable safety checklists for challenging situations and leveraging technology-based solutions like artificial intelligence and clinical decision support systems that enhance peri-procedural safety. As the field continues to expand and evolve, these concerted efforts aim to ensure that office-based anesthesia remains a safe, accessible, and highly satisfactory option for a growing number of patients seeking outpatient surgical care and ease. So join us on our podcast, Beyond the OR Walls, how office-based anesthesia is decentralizing healthcare today.
CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
Welcome back to Anesthesia Alchemy, Lynn and Garry Unplugged, the podcast where we distill complex perioperative topics into digestible, sometimes delightfully quirky insights for our fellow anesthesia providers. I'm your co-host, Lynn.
And I'm Gary, ready to unplug the myths and plug in the facts. Today, Lynn, we are diving deep into a segment of our practice that's growing faster than a resident's caffeine addiction during exam season.
And that's why.
Oh, yeah. And that is office-based anesthesia, or OBA.
And it's faster than a speeding bullet indeed, Gary.
Yeah.
And it's not just growing, it's exploding.
Yeah. Sure
We're
is.
talking about the fastest growing segment of anesthesia practice, and for good reason, it seems. Think about it. A decade ago, current estimates were around 10 million procedures per year performed outside of hospitals and ambulatory surgical centers. That's a significant chunk of change, both literally and figuratively, that should absolutely command the attention of nurse anesthetists, whether you're in academia or clinical practice.
Absolutely, Lynn. You know, it's phenomenal that has paralleled and perhaps maybe even been driven by huge increases in demand for things like cosmetic surgery over the past decade, and that tends to be growing. Just share you a little note with that. So it's not only in the United States, it's also in Mexico. And my wife and I had chatted 2 days ago, and she does a little bit of first assist work, and they had a mother and daughter that had some cosmetic tummy tuck in Mexico.
Yep.
Yeah, with their margarita. And so they show up in the ER, get a 2-for-1 to the OR, and abscesses in both. And she says when they opened them up, the pus that fell out of the abdomen where the cosmetic surgery was done was unparalleled to the bottles of wine that you and I share. Anyway.
I went for you. A nurse came into my hospital and you could smell her infection.
Oh my God.
She went to Miami.
Nice.
And they would not see her. They made her get on the plane, and the plane was postponed. And by the time she got back to North Carolina and got into our hospital, you could smell it.
And it's just not cosmetic anymore. We're seeing a wider variety and complexity of procedures in these office-based anesthesia practice, even in patients with more comorbidities, tongue twister there, and it's migrating into the office setting. And so that starts to raise our awareness a little bit. It's fascinating, Lynn, because traditionally offices were not a highly regulated, obviously as inpatient settings or other types of ambulatory surgery centers. So the exponential growth really forces us to pause for a minute and really examine that landscape for the services that we certainly offer in the office-based practices.
And that's exactly what we're going to do today.
Awesome.
Gary and I are going to unpack the why, the how, and the what if of OBA. We'll be addressing some commonly held beliefs among nurse anesthetists regarding OBA. And we'll also talk about the specific techniques that make it tick, the evolving safety standards, and even peer into the future of this burgeoning field. So grab your favorite brew, or if you're on call, please just drink some water, and let's dive in.
All right, Lynn. Well, let's kick it off with why. Why this meteoric rise in office-based procedures? You know, beyond the obvious demand for cosmetic surgery, what's really fueling this shift?
There's a lot of reasons. It's a multifaceted beast. Much like trying to get a straight answer from a surgeon at 2 a.m.
We know how hard that is sometimes.
Yes, I do. First off, as mentioned, the sheer demand for cosmetic surgery is a massive driver.
Yeah.
But then you add the allure of cost-saving potential for patients and the surgeons. It's often mean lower out-of-pocket expenses because of the avoided facility fees. And for providers, it offers increased efficiency and greater control over cost. One specific example from the sources even suggested that patients undergoing otolaryngology procedures saw reduced, ready for this, 95% in cost per procedure
God.
for offices when compared to the same procedure in an inpatient setting. That's how much it was reduced. That's not just a savings, that's a whopping amount of money.
Oh my God. That's incredible. And let's not forget,
95%.
isn't that crazy? I mean, so, hospital charges and
Yeah.
ambulatory surgery centers, which are now starting to compete with inpatient facilities. That's huge. Well, let's not forget about the patient perspective beyond cost. There's the appeal of things like the ease of scheduling, greater privacy, and ultimately, I think it's convenience, not just for the patient, but for providers. But, patients often do appreciate the more personal attention, less psychologically imposing environments compared to a large hospital. These places are beautiful in most instances, and it's appealing, and it is a customer service concierge kind of,
Right.
option for some patients. During the COVID-19 pandemic, that desire to avoid hospitals altogether further actually, at least in the literature that we've included in our references, has led to the popularity of office-based surgeries because it is a little bit more seclusive, if you will. Now, it's really about minimizing the strain on inpatient beds and addressing patients' fear of hospital admissions. Now, who wants to be in the hospital when they don't absolutely have to be and they're perfectly healthy?
Hospitals really are scary, even if you're not the patient.
Yeah.
Trying to find your way around is tremendously difficult at times. But from a surgeon's standpoint, it allows them to dovetail consults and follow-up visits with surgical procedures. That increases efficiency. Plus, they have more direct control over the cost to the patient, which is crucial for things like touch-ups or revision surgery.
Yeah.
The win-win-win scenario.
Absolutely.
Assuming, of course, that safety isn't compromised.
Which brings us to a critical point, Lynn. The increasing complexity of both patients, comorbidities, and procedures now being performed in offices. I mean, those are we're not just talking about minor skin excisions anymore.
Not just Mohs procedures.
No, not at all. And we're seeing substantial numbers of procedures of plastic surgery, ophthalmology, like cataract, refractory lens surgeries, which has been sort of the bane of nurse anesthetist practices, I think, as they mature in their careers. Dental anesthesia. Now, we've seen a lot of that in literature. And so that's one to pause and start to rethink on what that needs to look like when we're rendering those services. There's even interventional vascular procedures in these office-based.
I don't know
right?
about that one.
Varicose veins would be one of them. Even
Yes.
ears, nose, and throat surgery are migrating to the office-based setting. Now, the median age of office-based patients, okay, I'm going to just say this is a really younger generation, 61 years of age. And 39% are over 65. And by 2030, they say 80% of surgical patients are expected to have a BMI higher than what is considered healthy. I don't know what that number is today, Lynn, but the patient population's getting sicker with more comorbidities, and that is this was the same accolades outside of the non-OR anesthesia practices, right? They're
Right.
just ASA 1s and 2s, and they're not
not.
Yeah, I don't think I remember seeing a 1 or a 2 in the last 10 years in the non-OR settings.
I heard of a GI center that allows a BMI, hold on to your hat,
Okay.
up to 50.5.
Wow.
Can you imagine doing an EGD on that when you're sharing that airway?
Yeah, can you help me manage that? No, thank you. God almighty.
Very scary.
Yeah.
So listen, this isn't your grandpa's office visit anymore, is it? We're seeing tympanostomy tubes for children,
Yep.
cataract surgeries, even major abdominal surgery being considered for OBA in some contexts. And with these more complex patients, the need for robust anesthetic techniques and protocols that allow for a rapid and complete transition from initial recovery to street fitness.
Yeah.
Which is paramount.
Yeah.
This is where the concept of, I guess they were talking about fast tracking really comes in. Aiming for patients to bypass the labor-intensive PACU and be transferred directly to a step-down recovery unit.
Mm-hmm.
What?
Yeah.
But this requires short-acting and fast-emerging agents, minimal side effects, and effective pain and nausea control.
Yeah, indeed. You know, the ideal anesthetic for office-based anesthesia should be, and I'm going to put this in caps, SAFE, safe, or short-acting and fast-emerging, not dependent on bulky anesthesia machines, scavenging systems that are associated with pleasant recovery and minimizing PONV, applicable to a wide variety of surgeries, and of course, as we've alluded to earlier, economical. So in the words of Freiberg, it should, and I don't know if everybody knows Barry Freiberg. I know him and an acquaintance, met him at a meeting when I was in California, but his word is, it should give the illusion of general anesthesia, meaning that patients neither feels nor hears the surgery.
Well, that's the dream, isn't it?
Oh, as anesthesia providers, we aim to deliver on those promises to the patients.
But Gary, we need to really tackle the elephant in the room, or rather the wild, wild west in the operating room. One of the most persistent beliefs about OBA, especially among those less familiar with it, is the myth that office-based anesthesia is unsafe.
Ah, Lynn, yes, the dramatic headlines. Office-based surgery has been called out the wild, wild west of healthcare. Well, it was true in the past. Some offices weren't as regulated, leading to concerns about transfer policies, staff training, and emergent equipment. I can tell you, I do expert witness stuff over the years, and this is one of them, a lot. And, you know, there's even talk about a 10-fold greater risk of injury or death if procedures are actually performed in office-based settings rather than an ambulatory surgery center.
And that's where we, as data-driven clinicians,
you bet,
need to step in and apply some alchemy to those claims. Because while the concern is understandable, numerous studies attest to the safety of surgery and anesthesia performed in accredited facilities by specialists practicing within their area of credentialed expertise. Take the 1997 review by Morello et al., which looked at over 400,000 cases performed by the American Board of Plastic Surgery certified surgeons in 250 AAAASF accredited facilities over 5 years, and they found only a 0.47% complication rate, which is comparable to freestanding or hospital-based ASCs.
Oh, well, that's not so wild after all, is it? You know,
No.
and another study by Hofflin et al. In 2001 reported that 23,000 cases performed under general anesthesia in an office-based plastic surgery facility, also known as a OBPSF, for those of you that are trying to text it, had less significant anesthesia complications. Another study by Bitar et al. In 2003 reviewed 4,778 consecutive healthy patients undergoing plastic surgery in some of these office-based plastic surgery facilities under sedation, local anesthesia, with only 2 anesthetic complications. And those were hypothermia and PONV. Another study I want to actually allude to is the Beard et al. That was also published in 2003. Now, we're talking over 20 years ago, reported similarly low complication rates at about 0.7% with no deaths in 5,316 consecutive patients. These studies really challenge the conventional wisdom of the wild, wild west, don't they, Lynn?
Yes, they do. So it's not so much the wild, wild west. Now, about that shocking Vila et al. Study from 2003, claiming a 10-fold greater risk. But it's important to look at the methodology because the sources point out some significant problems. They didn't use actual case numbers, but rather an estimate of 140,000 procedures. And their analysis of adverse incidents revealed that out of 182 office incidents, only 15 patients underwent surgery. And of those, only 5 were in accredited facilities. The authors themselves suggested that the presence of nurse anesthesia may be a factor in more favorable outcomes. A follow-up study in 2006 by Clayman and Siegel on over 600,000 office-based operations in Florida from 2000 to 2006 found that the location was not as much a contributing factor as the regulators had suggested.
So I think, Lynn, here, the key takeaway is pretty clear. Office-based anesthesia is not unsafe if it's performed in an accredited facility by board-certified specialists who are credentialed for the same procedure in a hospital and who wisely select the appropriate patient population for office-based care. Now, we know they're pushing the envelope here. This is where the American Association of Nurse Anesthetists, or AANA, comes in. Their practice committee adopted guidelines for office-based practice and related statements on qualifications of anesthesia care providers in office-based settings all the way back to 1999, make it really clear that AANA standards applicable to care in hospitals and ASC also apply to office-based anesthesia. They even updated some of their guidelines, which they do on an annual basis for the most part on the practice committee. The last I remember, or at least the last that I read, was way back in 2019.
And these guidelines are comprehensive.
You bet they are.
They
I
really-
sat on the committee.
Oh, you did a good job. So the guidelines emphasize that the facility should have a medical director who establishes up-to-date policies and ensures the facility and personnel are appropriate and trained appropriately.
Yeah.
This includes compliance with all applicable laws regarding fire prevention, building construction, occupancy, accommodations for the disabled, occupational safety, disposal of medical waste, and drug supply storage administration. The nurse anesthetist must also adhere to basic standards of care, be present during the intraoperative period. Well, I certainly hope so.
Yeah.
And be immediately available after the procedure.
So, Lynn, what you're referring to really is it's not just anybody should be doing this, right? The personnel tending to the patient after anesthesia should be trained in advanced resuscitative efforts. Facilities need reliable oxygen, suction. You've kind of alluded to some of those standards, resuscitation equipment, emergency medicine, backup power sources. That's a big one, with enough space. And that's another big one, a big, space that's accommodating.
Can handle it all.
Yes, exactly. It gets pretty tight. Sometimes I actually look up on the walls and wonder if there's coat hooks where I could actually crawl up and hang from. It's so tight. Especially if we're treating children, appropriately sized equipment must be immediately available. This is a big one and a red flag. And those of us that go into these environments, we get accustomed to doing the easy ones. And it's that 1 out of 1,000 that rocks your world, right? As well as the family and the patient. So it all sounds like a hospital, but it's just on a smaller scale. And it's not that it can't be done. It's just that it needs to have the right standards applied. And I think we may talk about this a little bit later, but I know you and I have discussed about, standards in only about half of the states across the United States that from the state level. And so anyway, turn it back over to you with standard of care.
Standard of care is important regardless of the setting.
Absolutely.
There should be written emergency protocols for cardiopulmonary emergencies, internal, external disasters, malignant hyperthermia.
That's a big one.
Using general anesthesia, and patient transfers, and staff should be trained to perform them. These guidelines are updated, every 5 years?
Roughly.
Which is crucial in this dynamic field. The ASA even released a statement on outcome indicators in 2022, listing what should be considered when designing practices and improving the quality of care and safety for outpatient facilities, covering categories like patient safety, perioperative efficiency, medication safety, and PACU events.
So, Lynn, when someone actually asks about office-based anesthesia safety, our response really should be, it's about the how, not the where. It's about the accreditation, qualified providers, proper patient selection, and adherence to rigorous standards that are already out there that we should obviously apply to these settings. Now, it's really about quality improvement programs, continuous data analysis to really find and seek out the weaknesses and the breaks in our processes to enhance patient safety in these environments. This isn't the wild, wild west. It's a highly specialized and increasingly regulatory or regulated frontier, although it's only about half of the states. Nobody goes in with a ill intent to harm patients. But when we overlook everything that we've talked about here in this segment, that's when things go wrong. And that's when the legal sharks get pulled in. And I guess Shark Week was a few weeks ago, but whatever it's called.
Week. All right,
but that's
I
what
have
happens.
A tune for you. Do you remember this? Dun 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 dun.
Oh,
dun 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 dun. That's the Wild Wild West.
It is the Wild Wild West, but that's not office-based anesthesia.
Oh, I'm sorry. Forget that song. All right, anesthesia alchemists, let's get down to the brass tacks. The actual anesthetic techniques and innovations that make OBA not just possible, but highly effective. Garry, what's in our OBA toolbox?
Well, our toolbox, Lynn, it's brimming with precision instruments, no blunt objects, thankfully. The ideal anesthetic for office-based anesthesia has several essential features. The first one is short-acting and fast-emerging safe agents. Its delivery is not dependent on the anesthesia machine and scavenging system, although I would have that as backups. It's really focused on pleasant recovery rather than post-operative nausea and vomiting, and the applications and effectiveness for a wide range of surgeries, as well as economical principles. Now, I want to stop for a minute. That sounds pretty generalized, maybe pushing the envelope for some. I don't want this to be fragmented from accreditation and applying the appropriate standards of care. You know, one of the things that I say in lectures a lot is it's not the location that determines the anesthetic that you can deliver. It is the standards of care that determine whether you can meet the standard or not, determines where you can provide that anesthetic. So if you cannot provide the standard of care, then you cannot provide that anesthetic. And that I want to make sure that every single listener hears loud and clear.
And you want it economical.
And economical. Yes.
So it sounds like a tall order, but when we talk about this fantastic primary anesthetic technique being used specifically for cosmetic surgery, and that's deep sedation with a propofol ketamine or PK.
Yeah.
Infusion combined with local anesthetic injection by the surgeon. This technique offers distinct advantages to patients and surgical colleagues, providing an anesthetic experience superior to a typical hospital or ASC general anesthesia.
Literally, I did this combination today. So it really is a game changer. And that myth really is ketamine is a poor drug for office space or most procedures. Folks, the reality is we don't give ketamine in the doses that we did back in the 70s and 80s. Let's just start there, right? We're not given 200 milligrams. We're given 30 to 50 on average. But, you know, many times back in the day, that's when it was used alone or without any other hypnotics. You know, there's many facilities that have demonstrated the delirium sparing effects, you know, especially when you put propofol with GABAergic agents, propofol, midazolam, all those agents that work on the GABA A subtype A receptors. And doing that simultaneously with ketamine, we don't see that stuff, you know, so that's a really critical and crucial distinction for all of our listeners to make sure that, you know, again, to your point, Lynn, some of the literature out there, you have to be an informed consumer, and some of the literature is just a rant and it's just complete garbage and skewed. And you need to be able to pick out that skewed information.
Discern, yeah.
Right? I mean, it really, well, I'm not going to get on tangents about economics and stuff, but I fought that with IV acetaminophen before it came off patent. And it's just absurd what some of the studies that were out there that were.
Oh, really?
Another day, another time.
Are you a resident or CRNA looking to transition into independent practice? Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management tailored specifically for 1099 CRNAs. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Remember, that's aana.com/1099 or click the link in the description of today's show.
So that is a crucial distinction, but it's the synergy of these two drugs working together.
Yeah.
Because the poor emergence is eliminated and the advantages of ketamine are apparent. Dissociative effect provides analgesia, especially for skin, which is perfect for local anesthesia injection. And ketamine maintains the respiratory drive.
You betcha.
It blocks the NMDA receptors in the CNS, which may produce preemptive analgesia. It is not associated with PONV. It has an excellent safety profile, and it's inexpensive.
Oh,
it's
Lynn,
economical.
you can't beat that combination. You know, at many clinics, they mix 50 milligrams of ketamine, as I said, 30 to 50 and 50 mils of propofol, starting that infusion at 50 mics per kilo per minute, and they run it continuously until about 10 minutes before the surgery ends. Patients are told preoperatively that they'll awaken when the surgery is almost done. And the results? No excitation, no hallucination have been observed in many of these practices for over a decade. In fact, they note that emergence excitation is often seen after general anesthesia in hospitals, not the PK deep sedation for OBA. Now, adding ketamine to propofol also reduces propofol use by about 50%. And so if you want to talk about economics, that hits the mark too. And I will validate some of this stuff that's in the literature because I've used it on multi-level spines where we put cages in, fairly quick procedures. The ketamine propofol combination, I have had patients do push-ups in the prone position and extubate in the prone position, and they wanted to get out of bed and start running around the unit. And I wasn't even in PACU yet. And I'm like, okay, dude, you're a pretty big guy and I can't hold you down. Like, I think you play for the NFL, but it's more emergence excitation, I think is a great term. So,
well, also local anesthetics, they're absolutely foundational here, not just the PK infusions. For procedures like rhinoplasty or facelifts, surgeons directly inject local anesthesia into the surgical field. For the abdominoplasty and breast surgery, they can perform bilateral posterior intercostal nerve blocks from T5 or T6 through T12. A bilateral anterior intercostal nerve block from T3 through T10, respectively. And these use a mixture of lidocaine, bupivacaine, and epi.
Absolutely. Oh my God, ICNBs, intercostal nerve blocks. That really is the bane of some nurse anesthetists' existence. They think they're difficult. They're not. The myth is often that intercostal nerve blocks are difficult, dangerous, and poorly tolerated. We all know our anatomy, physiology. You just got to know where the nerve bundles are, the vasculature. But some of the sources do, in our reference list, do dispel some of this. The likelihood of a pneumothorax when a block is actually properly done, contacting the rib with the needle first and walking it off to the inferior edge, advancing it 2 to 3 millimeters, aspirating, and then injecting, minimal to 0% on the pneumothorax. I will tell you, it's the same way we put chest tubes. So also as an acute care nurse practitioner, I used to put tons of chest tubes in. Same technique that I did putting chest tubes in, although I was looking for the superior side of the rib. I didn't want to put my hemostat into the vascular bundle.
What?
Uh,
You're kidding.
yeah. Some of these facilities, they say that they've done almost 2,800 cases involving these intercostal blocks for breast and abdominal surgery, and most patients receive bilateral blocks. So 7 to 8 intercostal nerves per side without any evidence of pneumothorax. So it's safe. Just know your anatomy inside out. And, you can use that trusty dusty thing that we've talked about in the past. Maybe we'll talk about it again, is an ultrasound unit. Because you can see that stuff.
But what about the local anesthetic toxicity concerns? Because bilateral intercostal nerve blocks, 7 to 8 different levels, said studies have shown that even with higher blood levels of bupivacaine following bilateral IC&B compared to an epidural block, toxicity did not occur. Adding epinephrine also helps reduce this risk by limiting systemic absorption. But the DSO data supports the lack of toxicity with their specific mixture and volumes. Plus, since there's no need to seek paresthesia, patients can be sedated with PK before the block, which improves patient acceptance of the procedure. The duration of analgesia with bupivacaine added in with the lidocaine mix for IC&Bs is also a significant benefit, lasting 6 to 12 hours, which allows for early and comfortable discharge without parenteral narcotics.
That's outstanding. I mean, so Lynn, let's pivot a little bit. Let's start talking about airway management. There's another myth for some nurse anesthetists. They refer to deep sedation techniques as general anesthetics without an airway, which we've all done. That's usually followed by a look of utter horror by some of our colleagues. So what do you think?
Well, Gary, the source points out all mammals do, in fact, have a natural airway. What do they think people do when you're asleep? The office-based concept of the natural airway is that it is not out of control. Most patients' airways work very well under deep sedation, even in the prone or lateral position, without invasive airway devices like ET tubes or laryngeal mask airways. Intubation is not mandatory to avoid aspiration or improve oxygenation, except in rare emergency situations.
Which really is a relief for patients specifically, and honestly, us too. I mean, that's one of our biggest concerns and why there's pushback. But it avoids a whole host of other problems that are associated with intubation, right? There's certain malignant hyperthermia triggers, one of those being succinylcholine, difficult intubation, sore throats, accidental disconnects of the breathing system. How many times have we had that? The deep anesthetic depths needed to maintain for endotracheal tube placement, or while it's in situ, increased risk of aspiration during intubation, as well as extubation, post-extubation coughing and laryngospasm, leading to, ecchymosis of fresh incisions. And I'm sure our plastic surgeon colleagues would love to see that. It's a big one for patient satisfaction. Increased incident of postoperative nausea and vomiting associated with general anesthesia. That's a game changer if you can avoid that for our patients, right?
I will tell you that I've had, as a young woman, I had multiple surgeries, and I've had PONV after every single one.
Oh.
And I'd rather be in pain.
Yeah.
That is the most horrible thing in the world.
Yeah.
So I try very hard for my patients not to have that. So back to breathing. Spontaneous ventilation with room air is frequently adequate to maintain oxygenation. Oxygen supplementation is administered whenever needed, using nasal prongs or creative solutions for facial surgeries because of the oxygen around the face, like a Levine stomach tube. You thread through a nasal trumpet, or there is a way to securely attach the oral airway to an oxygen source. This allows for continuous oxygen flow without obstructing the surgical field or putting oxygen into the surgical field with the cautery by the surgeon. The end-tidal CO2, while we have that pretty much everywhere in the hospital, you don't always see that in the office-based setting. And mouth breathing can defeat its capability with nasal prongs. But adequacy of ventilation during MAC by visual and clinical assessment meets the ASA standard. You don't have to have an end-tidal CO2 monitor available. The best monitor is the nurse anesthetist.
Yeah, absolutely. You know, the critical caveat here, I think, is spontaneous ventilation is essential for these various types of sedation techniques as well as success. So things like narcotics, which actually can suppress ventilation, should be used sparingly, if at all, based on what we're doing. Limiting narcotics also has the added benefit of reducing postoperative nausea and vomiting, obviously. And it's really about low opioid prophylactic antiemetic, or LOPA. And that was summarized by Dr. Blake in one of our readings that we've included in the reference list.
So I'm very excited about this next topic. We're seeing incredible advancements in connectivity and technology as we move beyond the drugs and into the digital realm.
Yep.
Technology-based solutions will likely be integral in enhancing peri-procedural safety. Think about early detection of clinical deterioration, effective drug infusion, and triage during critical events. This includes, here we go, artificial intelligence techniques.
Yes.
With closed-loop anesthesia delivery systems, also called CLADs, and electronic applications of pre-anesthesia patient education decision aids.
Oh, near and dear to my heart, Lynn. AI-powered tools. And that'd be things like hypotension prediction indexes, or HPI software. And they are becoming invaluable now. And I'm sure many of you in acute care settings are incorporating that into your practice. HPI uses advanced AI algorithms, machine learning, to analyze real-time hemodynamic data. It is able to generate predictive indicators, not only impeding hypotensive events, but long-term outcomes like acute kidney injury. You know, these early warning systems allow us really to intervene proactively before complications arise, adjusting fluid administration, vasopressor use, anesthesia management to maintain stable blood pressure. And in many cases, this is even when on the monitor, the blood pressure looks normal. There's a lot of things going into these algorithms. So this is moving from a reactive to really a predictive hemodynamic management of our patients.
This is Jackie Rolls, President of the International Federation of Nurse Anesthetists. I'm inviting you to attend the 15th World Congress for Nurse Anesthetists, May 7th through 9th, 2026 in Brisbane, Australia. I promise you that you will love meeting nurse anesthetists from around the world, attending the multitude of Congress sessions, and exploring the many unique experiences that Brisbane has to offer. Hold a koala bear, feed kangaroos directly from your hand, climb Story Bridge, one of the only 3 climbing bridges in the world, or travel to snorkel the Great Barrier Reef. This is one Congress you do not want to miss. Cheers.
Well, because it catches things before we might be able to catch them.
Absolutely.
And that's where the HPI Decision Support System, or HPI DSS, comes in. It takes the HPI's predictive capabilities and combines them with physiological variables from the hemisphere monitor to provide comprehensive hemodynamic manager guidance. It's essentially a smart algorithm that when HPI rises above 80%, it checks parameters like stroke volume variation, or SVV, maximum rise of arterial pressure for contractility, and dynamic arterial elastance, EDEN, for pressure responsiveness.
So if your HPI is high, it can recommend a fluid bolus. If your stroke volume variation, or SVV, is high and EDEN is high, or a vasoconstrictor if your SVV is high but your EDEN is low, and that indicates vasoplegia, like I experienced today. Epi was the drug of choice. If your stroke volume variation is low and your maximum rise on your arterial blood pressure, so this is what goes into the algorithm. So if it's low, it might actually suggest an inotrope for symptoms like myocardial depression. If things like your maximum rise of arterial pressure is high, then perhaps a vasoconstrictor is recommended for things like vasoplegia. It's like really having a hypervigilant co-pilot who never actually sleeps. Hopefully nobody's sleeping other than the patient. But it provides those alerts. Stability for HPIs less than 50 alerts you for HPIs that are less than 80, and it warns you if your HPI is greater than 80. So this is a new emerging tool that I think in time, when it's perfected, will be like your pulse oximeter. That's how it's going to revolutionize things.
Wow.
Yeah.
So this integrated approach ensures tailored recommendations based on the patient's specific hemodynamic profile. And I'm sure it has limitations like the inherent uncertainty of the FlowTrack platform's CO calculations, especially with vasopressors, and the need for accurate data input and user validation. But it offers significant advantages over closed-loop systems by providing flexibility for personalized decision-making. It's about empowering nurse anesthetists with real-time information and precise recommendations, which enhance the accuracy and efficiency of decision-making. It's a tool to use while we're watching carefully and thinking through everything. It may catch things before we do.
Absolutely. Lynn, another crucial innovation that's been gaining traction is simulation training. Personnel in offices might have less experience managing medical emergencies and often less support than in the hospital. Oh my God. So many things go off in my head related to this. Simulation training really helps to introduce staff to handling these emergencies. Number one would be power button on the defibrillator. That's number one. Let's learn where that is, and then we'll get to connecting the pads with the little connectors. Pilot studies really have actually demonstrated that audio-visual support systems utilizing emergency manuals on screens as well as announcing next steps, or what I like to call closed loop communication, actually improves diagnostics and therapeutic accuracy, as well as efficiency during these patient deterioration scenarios. And I will tell you, I can almost bet you, like the attorneys, all of them should have called me, because I guarantee you closed loop communication was the first epic fail in a lot of these office-based procedure failures and leading to death, because that's what it does. It leads to death without question, because people are in panic mode. They're in panic mode, right?
Right.
And so they get tunnel vision. It's not that they don't know the information. Well, I'll say that with tongue in cheek, because I've seen people that don't know where the power button is. They're overwhelmed by the machine because they're anxious. And so I think, anyway, I digress a little bit. I just think that simulation training, I can't underscore that and reinforce that enough. Going through and making sure for that one event that can cripple an office-based practice overnight.
And I was blessed to be accepted and go through school at the University of Pittsburgh. And John O'Donnell had a simulation building.
Oh, yeah.
And we were exposed to this. And I would have thought that I was much smoother and moved more specifically in an emergency. But even in a false emergency, even in an acting emergency, I was flying around the room like a lost hummingbird. And I wouldn't have believed it if I hadn't seen it on the film.
Right.
So it's very, very, very valuable.
Absolutely.
I agree.
Yeah.
So it's like it's a smart assistant for emergencies. And checklists have proven to be incredibly useful tools. The Institute for Safety in Office-Based Surgery offers 4 checklists for OBS, sedation, and refractory surgery. One study showed that implementing a customizable surgical checklist in an office reduced complications by 12.4%. These small documents ensure everything is in place before, during, and after a procedure, and it's about standardizing safety initiatives.
Absolutely. And these are all part of a broader push to standardize care, ensure safety in these environments. The American College of Surgeons actually calls for all office-based surgery centers to be accredited by national state accreditation organizations. You and I, Lynn, were talking about this a little bit earlier. It's actually quite surprising that not all 50 states require accreditation for offices.
Unbelievable.
Right? The ASA actually emphasized a widespread accreditation and had stated it creates a more transparent process for ensuring really that office-based anesthesia providers are operating within their scope of practice. I'm not going to get into the politics there, but it's not just about flashy technological inconvenience. It's about solid fundamental safety practices. And so to our CRNA colleagues out there, make sure that you have all of these in place with your checklists, with all the appropriate standards, accreditation, and work with your team in those office-based practices. And I know the number one thing that comes up is money, right? Do it safely so that you don't sit, and I'm not sitting during deposition trying to defend a breach of standard of care.
Hi, this is Jackie Rolls, President and founder of Our Hearts, Your Hands, a global support anesthesia community. We'd like to thank all of our prior donors and also say that we are accepting donations, welcome donations, to send a nurse anesthetist or even a nurse from a low-resource country to get further academic education or attend professional conferences or even equipment for some companies. Thank you so much for your support.
All right, Gary, and all anesthesia alchemists, let's talk about tailoring the magic to the patient and the procedure selection. This isn't a one-size-fits-all party, Gary. Who's invited to the party? Who's invited to the OBA shindig? And who's respectfully declined from the party?
Precisely, Lynn. The ideal candidates for office-based anesthesia are typically ASA physical status 1s and 2s, perhaps stable ASA 3 patients. Those with well-controlled chronic medical conditions. I can't not laugh, right? We're looking for individuals with pre-existing medical conditions that are not reasonably expected to be adversely affected by the anesthetic or the procedure that they're actually having in these environments. So a robust preoperative assessment is absolutely critical here.
Absolutely. Because it's not just the surgery, it's the comorbidities of the patient. You've got to consider a multitude of factors, really digging into the patient's health. The sources detail quite a comprehensive list. The abnormalities of major organ systems and the stability and optimization of any medical illness. If they have a difficult airway, if they're morbidly obese, if they have obstructive sleep apnea. Morbidly obese patients, especially those with sleep apnea, are generally not operated on in the office and are best cared for in a hospital setting. Some guidelines even suggest patients with a BMI of 35 or higher requiring general anesthesia should not be considered suitable candidates for non-hospital surgical facilities, except in extraordinary circumstances. But as we discussed earlier, those limits tend to get pushed. The highlights that need for a cautious approach given the rising obesity rates. Previous adverse experience with anesthesia and surgery, including malignant hyperthermia, is forbidden. It's explicitly stated that it's not advisable to anesthetize MH-susceptible patients if there's no immediate access to blood gases, electrolyte measurements, and medical backup. This is a huge safety red flag. Current medications, drug allergies, even including latex allergy. The time and nature of the last oral intake, history of alcohol or substance use or abuse, and a big one for discharge, the presence of a vested, responsible adult who assumes responsibility specifically for accompanying the patient from the office. No Uber for a direct discharge, unless they didn't get anything but local anesthesia with without sedation.
Yeah. So, Lynn, it's really about thorough preoperative evaluation, not just and how many of us do this? A quick glance. Don't do that you're going to get sucker punched at some point in your career. And this might include like routine preoperative laboratory testing. You know, there's some sources that actually question routine use for healthy patients undergoing ambulatory surgery. Don't forget about informed consent also. We haven't talked about that. We're not going to go into detail, but just make sure that that's in your back pocket. Patients need an adequate explanation for the proposed treatment, anticipated outcomes, the significant risks that are associated not only with the procedure, but with the anesthetics and available alternatives. The dialogue with your patient must be documented, and it's about managing those expectations and ensuring the patient actually comprehends. And I'll digress a little bit. I have the luxury, Lynn, I sit there, I go to work early. I'm setting up the OR at 5 a.m. every day, and there's one goal for me to go there. Well, there's two goals. The first one is make sure all my stuff is there. It's all properly set up. The second goal is exactly this, ensuring comprehension. I spend 40 minutes to an hour with my first patient and their family, discussing what the expectations are and what the outcomes are anticipated. So I realize that's not reality. I live in fantasy land, but it makes a difference. I will tell you that, because patients and family members acknowledge it every single time.
I'm sure they appreciate that.
Yeah.
So which procedures typically get the green light for OBA? I mean, historically, we know it's been cosmetic surgery, which remains a huge segment. But procedures like abdominoplasty, various types of mammoplasty, augmentation, mastopexy, implant exchange, gynecomastia, facial rejuvenation, brow lift, blepharoplasty, rhinoplasty, lipoplasty are commonly performed.
Indeed. And that net is widening, Lynn. We're seeing cataracts, refractive lens surgery with complication rates that are similar to or lower than hospital settings. You got PD tympanostomy tubes placements. They also show comparable long-term outcomes in offices versus operating rooms. So those ASCs are going to start losing that population. Beyond that, recent analysis from mobile anesthesia practices in New York and some of the studies actually highlighted that the top 5 most common procedures in office-based settings are colonoscopies, prostate biopsies, angioplasty, anything urology, as well as uterine fibroid embolism. So it's a pretty diverse portfolio, and that is continuing to grow as we move forward.
So let's just zoom in on a few specific procedures with unique considerations. First up, liposuction. It's one of the most common cosmetic procedures, but despite its popularity, it can be associated with significant complications. The large volumes of the tumescent solution that are injected, approximately 70% of it is absorbed, and hypervolemia is a real risk. Fluid management must balance blood loss and urinary output with this absorbed infiltrate, and it must be tracked very carefully.
Well, and let's not forget temperature. The large volumes of infiltrate are usually not warmed. That increases the risk of hypothermia, especially in prolonged procedures. Actively warming patients with our warming devices should be available and used. Local anesthetic toxicity from the injectate is also a concern, potentially leading to cardiac dysrhythmias and, heaven forbid, death, which we see in the media. While some plastic surgeons use lidocaine doses up to 35 milligrams per kilo in the tumescent liposuctions, higher concentrations have actually been reported, surprisingly, as safe. So as anesthetists, careful attention must be really focused on maximum dosing with epinephrine limits. Those are crucial, and your knowledge and contribution and collaboration with the surgeons is an imperative.
And in this case with liposuction, there's an increased risk of a DVT, deep venous thrombosis, with liposcopic procedures. Prophylaxis has to be discussed, and mechanical anti-embolism devices should be used with low molecular weight heparin for high-risk patients. The sources recommend not performing large volume liposuction over 5,000 milliliters total aspirate or 2,000 milliliters as an adjunct, or combining liposuction with procedures like abdominoplasty in an out-of-hospital setting. The liposuction itself is a huge surgery, and abdominoplasty is too. The physiological stressors are just too high, and they should be done in a hospital.
Well, next, let's look at facial cosmetic surgery like blepharoplasties, rhinoplasties, facelifts. These are often done with local anesthesia and supplemental sedation. You know, the main technique or the main unique risk here, alarmingly and not surprisingly, is operating room fires, right? You got the fire stick that's near an oxygen source. So, you know, those procedures frequently involve flammable skin prep, supplemental oxygen, and then the fire stick or electrocautery. So again, knowing what the triad for OR fires is and how to extinguish and make sure that that triad does not occur together.
So that's a pretty terrifying trifecta.
Yeah.
And to mitigate this, make sure that flammable prep solutions must dry completely before the drapes are applied. Drapes should avoid tenting to prevent oxygen-rich reservoirs. And remember that an FiO2 greater than 30% or the use of nitrous oxide is considered an oxidizer-enriched atmosphere. Oxygen should only be used when needed and turned off when near an ignition source like cautery. It's a simple yet life-saving protocol.
Well, and Lynn, let's not forget about what seems to be in the media a lot lately is dental surgery, which presents some other special challenges. Dental offices are often regulated by dental colleges whose guidelines might not align with medical regulatory authorities. So a nurse anesthetist providing services there needs to verify that all requirements are in place, not just for the dental surgery, but for us as anesthetizing locations. So dental ORs are often smaller. Dental chairs offer limited positioning. Essential engineering elements like backup power and suction might not be present. And so, once again, applying the standards of care for a nurse anesthetist dictates whether you can anesthetize in that specific location.
Well, certainly the dental office is not ideal for surprise intubation, is it? It'd be a nightmare. The main anesthetic challenge is the shared airway anyway.
Oh, yeah.
We're talking about clearing secretions, blood, water from drills, or interference from foreign objects while maintaining ventilation without the endotracheal tube. Plus, patient education is key, as many dental patients underestimate the preparation needed for anesthesia, like the NPO status.
Yeah, that's a big one. You know, and finally, Lynn, you know, bariatric surgery. I cringe when I even look at the words. You know, that's a hot topic. It's a debate. You've alluded to it already with BMI. You know, given the complexities and potential complications associated with high BMIs or obesity, some guidelines, like the British Columbia guidelines out of Canada, recommend against general anesthesia for patients with BMIs over 35 in non-hospital surgical facilities, except in extraordinary circumstances. Now, I don't know what those are. You know, that starts pushing the envelope. You know, more evidence really is needed for specific recommendations here. This is a real gray area, and I know people go out, well, they're tall, so I expect them to be a little heavy. You know, we can make up all of the scenarios, but it's a real gray zone. It is clear that while office-based practices are expanding, patient and procedure selection remains paramount, and we really need to stick to some guidelines to make sure that patients are safe and that everybody wins at the end of the day.
So to wrap things up, Gary, let's talk about the 4 C's that really embody the future and ongoing success of safe OBA practice: communication, competency, connectivity, and collaboration.
Oh, that's an excellent framework, Lynn. Let's start with communication. It's the bedrock of patient safety, isn't it? I mean, 90% of the time, Our problems are a failure to communicate. Effective communication in office-based anesthesia spaces, they really should focus on structured patient handoffs, routine reporting, review of adverse events for all stakeholders in that environment. We really need to be comprehensive, interdisciplinary communication colleagues that really include discussions among, peri-procedural teams regarding the appropriate patient selection. Can we implement the appropriate care pathways? And that really also alludes to proactive triage planning. Can we ensure a safe patient transition of care when it's needed? Customizable communication strategies, that applies really to every phase of care for the patient. So can we engage the entire medical team and even the patient to potentially reduce those preventable negative outcomes just through simple things like communication? And I'll give you one example is wrong site procedures. I always make fun of it sometimes with patients. They come in for a craniotomy or a liver or a pancreas. I talk about their, allergies, etc. And I say, so we're doing your left knee replacement today. And everybody looks up. I said, all right, I got everybody's attention. So then we continue that conversation. Probably shouldn't be joking about that, but anyway.
It still happens.
It does happen.
So we can't really overstate the importance of clear, consistent communications. So next up is competency. This focuses on ensuring that anesthesia professionals receive effective, office-based practice safety education. OBA can be a relatively isolated environment, carrying the same potential risks as any location where surgery and anesthesia are performed, but with no other anesthesia backup. After several recent high-profile adverse incidences, some of them with death, organizations like the AANA, the ASA, and accreditation agencies, such as all of the ones with a whole bunch of A's in their name, AAAHC, AAA, ASF. All of these organizations are striving to implement a standardization of care to ensure patient safety.
Lynn, and this is where the glaring gap in our traditional training comes in, right? A recent survey actually found that only 16% of academic anesthesia programs provide office-based anesthesia services in the community. And so that limitation exposes many of our nurse anesthetist residents. Literally, only about 2% of them actually experience these services. I remember I went into reproductive clinic, and that was kind of interesting, but it was pretty tight in that room, and there was a lot of safety concerns. So it's no wonder that many nurse anesthetists in private practices might be a little reluctant to provide office-based anesthesia services, and perhaps maybe even demand hospital-level setups, as a source of sort of pointing out skill in achieving variable levels of sedation with infusions of anesthesia of various levels, take your pick. It's essential for the success in office-based anesthesia practices, and it's not easily attained, for not just anesthesia residents being our students, but even anesthesia providers, because the universality and availability of anesthesia machines, invasive airway devices, like we experience in hospitals and ASCs, it really, is about putting the patient to sleep, putting in the tube, turning on the vaporizers. We really need in these environments to be thinking outside of the box. And in this case, an anesthesia machine, they make portable anesthesia machines, the ability to deliver ventilation, positive pressure, ventilation is critical. And when you need it, you need it. And sometimes, especially when we start talking about BMIs over 35, nasal cannula sometimes is not going to cut it in these environments.
But the ASA suggests that widespread accreditation of providers would create a more transparent process for assuring that office-based anesthesia providers are operating within their scope of practice. New statements continue to be published by the ASA and the Anesthesia Patient Safety Foundation as OBA evolves. But it's imperative that the ASA take measures to provide residents training in OBA and understanding that an extensive skill set is necessary to be successful.
Absolutely. So Lynn, let's move on to connectivity, which for this discussion involves technology-based solutions that will likely be integral in enhancing peri-procedural safety, certainly in office-based anesthesia practice. We've touched on this with some HPI DSS systems, but it's much broader than that. Technology can actually assist with early detection of clinical deterioration, effective infusion of drugs, and triaging during critical events. This includes things like cutting-edge developments like artificial intelligence technologies, closed loop anesthesia delivery systems, or CLADs. And if you haven't seen or heard this stuff yet, globally, they're coming. Globally, they're very mature. We just haven't allowed them in the United States yet. And that maintains specific levels of unconsciousness during intravenous anesthesia. Now, CLAD systems highlighted in primates historically, now in humans to cover the anesthesia gaps globally, are even soon to be piloted in human trials, likely in the United States, very shortly. And that moves towards a personalized medicine approach to anesthesia.
But let's not forget the electronic pre-anesthesia.
Of course not.
Patient education decision aids for monitored anesthesia care. But these tools provide information on anesthetic options before surgery. They help the patients better understand terms like sleep for a procedure, along with the risks and benefits of each choice. These advancements and clinicians in better understanding office-based risk and implementing early, appropriate interventions. And it's about leveraging every tool at our disposal.
The fourth C, collaboration, it really is vital to the successful execution of safe office-based anesthesia practices. And this involves sharing fundamental resources such as core curricula of safe office-based anesthesia delivery to not only our students or trainees locally at our facilities, but in the schools. And the literature has really been tracking office-based anesthesia safety curricula for students and trainees over the years, just because it's growing in such large volumes right now. There are some educational curricula and training programs for medical students, anesthesia trainees. It does require a structural teaching approach, discussions, clinical expertise in office-based anesthesia. And that's probably an area that, perhaps the ANA could actually get involved with.
But this is an important first step toward expanding OBA training worldwide and preparing the next generation for more office-based procedures. It focuses on creating a community that shares knowledge, doesn't keep it to themselves, and best practices to promote safe global adoption.
So, Lynn, after all this discussion, what's your take on the future of office-based anesthesia? Is it the wild frontier or a well-tamed, albeit expanding landscape?
I'd say that the future of OBA seems increasingly sophisticated and assured. The focus is sharpening on enhancing global communication, connectivity, competency, and collaboration, the 4 C's.
Yeah.
But we've moved beyond the initial Wild West narrative, though remnants of that skepticism might still linger in some corners. The evidence, though, strongly supports that in experienced hands, OBA techniques deliver an anesthetic for office-based cosmetic surgery superior to the usual general anesthesia performed in hospitals and ASCs. These techniques are safe. They do not require expensive equipment other than an infusion pump and vital sign monitor.
Yeah.
This avoids sore throats and nausea, provides post-operative analgesia, and are very well received by patients and surgeons.
Indeed. And the sources, and certainly in our references, consistently point to safety when procedures are performed in accredited facilities by board-certified specialists. That includes nurse anesthetists who wisely select patients appropriate for office-based care. The continuous efforts by organizations like AANA, ASA, American College of Surgeons to standardize care, promote accreditation, that's pivotal when these various organizations join the forces in ensuring safety. Now, educating the next generation of anesthesia professionals on key safety aspects of office-based anesthesia delivery is really vital to continue expansion as well as our quest to eliminate adverse events in some of these environments. And it just depends on the type of procedure that you're doing. And I'll use the dental offices are getting the rap right now in the media. So we got some work to do still.
But these technological advancements are really exciting. And future technologies incorporating AI with appropriate, easy to use clinical decision support may make successful delivery of office-based anesthesia among anesthesia professionals even more seamless. Plus, the standardization of accreditation amongst OBA sites will ensure safe practice spaces for patients and providers. Ultimately, the safe expansion of OBA even to developing nations may lead to further access to much needed procedural care. It's about, bottom line, the right care to the right patient with the right procedure in the right setting, in the right amount, and at the right price, delivered by the right health care provider.
Beautifully summarized, Lynn. It's clear that office-based anesthesia is not just a trend, but a fundamental shift in healthcare delivery. And we're seeing it, every single one of us. It requires us to be agile, informed, committed to the highest standards of safety, standards of care, regardless of the patient or the physical setting of the anesthetizing location. And on that note, remember, folks, continuous quality improvement, data analysis, looking at what we do and evaluating what we do every day are critical to identifying our own weaknesses and making the field even safer as we move through this journey.
Absolutely. And always remember to think outside the box, especially if that box happens to be an anesthesia machine. Thank you for joining us on this deep dive into office-based anesthesia.
It's been a pleasure, as always, Lynn. To our folks out there in the audience, join us next time for Anesthesia Alchemy, Lynn and Garry Unplugged, as we tackle another fascinating topic. And until then, stay safe, stay sharp, and keep those airways patent.